Good morning, everyone. Thank you so much for joining us. I'm just going to give folks a minute as you are all signing in, and then we will go ahead and get started. In the meantime, please go ahead and use the chat function to let us know where you're from, where you're calling in from, and your name. All right, we are going to go ahead and get started. Welcome, everyone. We are really looking forward to this webinar this morning. Just to let you know, this session is being recorded and you are joining us to hear more about ending veteran homelessness through housing first. My name is Amanda DeFalco, and I'm the Deputy Director and Veteran Strategy Lead with the Built for Zero movement at the Canadian Alliance to End Homelessness. I'm your co-host and moderator for the day. And this webinar is being co-hosted with our veteran partners, the Respect Forum, and I'll be passing it over to your other co-host and moderator, Sarvan, who's joining me today from the Respect Forum. Before we do that, I'd just like to say a few more words. So before we begin, I'd like to acknowledge the land that I'm joining you from today, which is the traditional territories of the Mississaugas, Haudenosaunee, Neutral-Wendat, and Anishinaabe. These lands are protected by the Dish with One Spoon Wampum Belt Covenant. I appreciate the contributions of all First Nations, Métis, Inuit, and other Indigenous peoples who have cared for, shaped, and strengthened communities from coast to coast. I'm grateful to live and work on these lands, and as a settler, I acknowledge that I've directly benefited from the painful history in our country and am committed to doing better to unlearning the beliefs, attitudes, and actions that contribute to oppression, discrimination, and I invite you to take a moment to acknowledge the lands that you're joining from today and reflect on how you can also help support the actions within the Truth and Reconciliation. This work wouldn't be possible without the support we receive from both Veteran Affairs Canada and Employment and Social Development Canada. And we're not only grateful for the financial support, but very much appreciate working together as thought partners in this work to end both chronic and veteran homelessness. We've got an incredible lineup of guest speakers for you today who have such extensive experience in both research and practice, and I'll be introducing them shortly, but this is the order of the presentation. We will let the presenters present their materials first, and then at the end of the presentations, we'll have time for a Q&A. A few housekeeping items about the Q&A. We'll be using the chat function, and Sarvan and I will be moderating the questions and asking the questions at the end. Si vous préférez demander votre question en français, vous pouvez écrire par utiliser la fonction de chat. Nous pouvons traduire pour les présentateurs anglophones. All right, and with that being said, I'm going to go ahead and pass it over to Sarvan.
Thank you, Amanda. Just let me share my screen. Perfect. So good morning, everyone. Thank you, Amanda, and thanks to the Canadian Alliance to End Homelessness for allowing me to be with you this morning. I am Sarvan Rupnel, National Coordinator of Academic Outreach, Women's and LGBTQ2+ Outreach, and Program Evaluation for the Respect Forum. The Respect Forum is a non-profit organization which aims to ensure that those who run to danger in service of their country and community have access to the support and care they need. Our mission is then to promote collaboration and create focus through networking and knowledge sharing to help improve mental health services and reduce homelessness for men and women in uniform service who run to danger. We have several activities which can take place thanks to the financial support of Veterans Affairs Canada and the collaboration with Canadian Forces Morale and Welfare Services. Our main mandates are to run Respect Forum meetings in 25 cities at least twice per year, bringing service providers together to promote knowledge exchange and collaboration, to host specialized fora addressing issues specific to women and indigenous populations and homelessness, to provide a map of local resources through the Respect Map initiative to inform planning and policy at the local, regional, and national levels. And finally, to promote collaboration through a website, newsletters, and social media. Our vision is that collaboration is key. As you may know, services are complementary to each other and they must be known and referred by other organizations. So to this end, we consider that organizations serving veterans and emergency responders can collaborate to develop the services, and organizations serving the general population can be educated and trained to serve specific population of veterans, emergency responders, and their families. To assist and support organizations that serve uniformed personnel, the Respect Forum offers various activities, including the Respect Map, our mapping platform of services for uniformed personnel, our women's and LGBTQ2+ outreach, with several events to share knowledge and expertise around gender specificity in the uniformed professions. Indigenous outreach with our Indigenous Advisory Circle to provide collective advice, guidance, and wisdom to facilitate and improve Respect Forum outreach and collaboration for the benefit of Indigenous men and women veterans and emergency responders. And finally, our academic outreach with various events and networking to promote the advancement of research in the field of uniformed personnel welfare. If you have any questions about the Respect Forum and our activities, please feel free to visit our website and social networks or contact me directly. Amanda will be able to share with you my PowerPoint where you can find my contact information. Thank you all for your attention. Merci à toutes et à tous pour votre attention, and I'll turn it back over to Amanda.
Oh, you're on mute, Amanda. Sorry.
Thank you. The bad habits of Zoom.
Yeah.
First up is our first guest speaker, Dr. Tim Aubry, who is a full professor in the School of Psychology and senior research at the Center for Research of Education and Community Services at the University of Ottawa. Throughout his career, Tim has collaborated on research projects with community organizations and government at all levels, contributing to the development of effective social programs and policies. He was a member of the National Research Team and the co-lead of the Moncton site in the At-Home Chez Soi demonstration project on Housing First of the Mental Health Commission of Canada. He was holder of the Faculty of Social Sciences Research Chair in Community Mental Health and Homelessness at the University of Ottawa. He's trained as a community clinical psychologist. He completed his MA and PhD at the University of Manitoba and his BA in honors at St. Francis Xavier University. In 2013, he received the Contribution to Evaluation in Canada Award from the Canadian Evaluation Society. He is a fellow of the Canadian Psychological Association and Society for Community Research and Action. Thank you, Tim, so much for joining us, and I will pass it over to you.
Great. Thank you, Amanda, for the kind introduction. Et bonjour tout le monde. C'est un plaisir d'être ici aujourd'hui. Thank you for the invitation from CAH and Respect Forum to talk about a very important topic and also for the important work you're doing towards ending homelessness for veterans. I'll just share my screen. Amanda, can you tell me, can you see the screen? Is that, okay.
Yes.
Okay, so I'm going to focus on, from a large project that was done in Canada, research on the effectiveness of Housing First as a strategy to end homelessness, and how it can be applied specifically to ending homelessness for veterans. So just to put this into context, we know that veterans make up a significant subgroup in the homeless population. If we look at a recent point in time count across 61 communities in Canada, with 32,000 people identified as being homeless in a 24-hour period in April 2018. You can see that among that group of people who were homeless, about 5% self-identified as being veterans. These were veterans in the armed forces, Canadian Armed Forces, or with the RCMP. But it was really a small group who were veterans of the RCMP. It was mostly people that had served in the military, Canadian military. Now, as I said, I'm going to talk to you about this large research project just to set it up. It got started over 10 years ago, and it was focused really on testing a model called Housing First, targeted to people with serious mental illness who make up a significant portion of people who are homeless and who essentially have trouble ending their homelessness. So this was involved Health Canada and through the Mental Health Commission of Canada. It was very large, $110 million were invested to develop new Housing First programs in 5 cities across the country, and also to do some rigorous research on their implementation and effectiveness. So what is Housing First? Historically, when we talk about ending homelessness, the favored model for years, and it still exists across Canada, it was really to try to help people up, we call it a staircase or a continuum, so that they would be ready to essentially live independently. But the thinking was for people who were chronically homeless, so people who couldn't get out on their own, they would need some help developing life skills, dealing with complex health issues, mental health problems, often combined with addictions and so on. So this was the kind of the model. People would go up the staircase eventually to get to permanent housing. What Housing First does is it collapses the staircase and essentially moves people without any preconditions. It doesn't require treatment compliance. It doesn't require psychiatric stability. It doesn't require abstinence. It moves them directly into permanent housing. So that's the simple idea. So rather than go up the staircase, go right into permanent housing. So the model we tested is called the Pathways model of Housing First. There's a housing component where people get to choose housing. It tends to be rentals. In the case of our study, it was in the private market, although Housing First is being implemented in social housing across Europe and even in parts of Canada. Essentially, the key part to the housing is helping people afford the housing. So they get a rent supplement, a housing benefit, so that they're only paying 30% of their income towards their housing. And then it's combined with support that can respond to their needs. And there's 2 main models. What we tested in this particular project was a model for people who had what we considered a high level of needs, in terms of they had lower levels of functioning. They often had comorbidity in terms of mental health problems, often combined with addictions and so on. It was a wraparound model called assertive community treatment. And you can see it's 1 to 10, the staff to client ratio versus intensive case management, which is more individual based, and it's typically 1 to 12, 1 to 15. And it's less intensive, but it's still intensive enough. And that was for people who we assessed as having more moderate level of needs, but still a serious mental health problem. So the design of the study, this was a trial. So we randomized people into either receiving housing first, and they received either this assertive community treatment or intensive case management, depending on their level of need. And because of the resources, we were able to study this model very thoroughly. We were able to kind of take a look at how to implement it. We were able to look at a whole range of outcomes. We followed people for 2 years. They started out absolutely homeless. And then we looked at how successful they were in terms of moving into housing, but also in terms of what kind of improvements they were experiencing in terms of their health and social outcomes. We also did an economic analysis that I'll just touch upon very briefly. So who was in the study? Well, you can see we had over 2,000 people. Over 1,100 received housing first. Treatment as usual, that was all the services that were available in the 5 cities. So it was everything but housing first. So that was what the comparison was about. You can see we had about a third that were women, and these were folks who had significant mental health issues that were long-standing. About a fifth self-identified as being Indigenous, and they typically had experienced chronic homelessness. You can see the lifetime, total lifetime in homelessness was 5 years on average. And then about 2/3 had a serious mental health problem combined with an addiction, so a concurrent disorder. And then lots of physical health issues. Over 90% had at least one chronic medical condition. Now, there was a subgroup who were veterans. So we took a look. It was a little bit over 4%. So similar to the prevalence in the point in time count, as you can see. And you can see the characteristics. About 80% were men, 20% were women. What we found, though, is in terms of the demographic, social, and health characteristics, there really wasn't hardly any differences between the veterans in the study and the non-veterans. The only differences, in fact, were level of education and whether or not people had been victims of a crime in the 6 months prior to getting into the study. We did see a trend towards significance where veterans were more likely to be diagnosed with a post-traumatic stress disorder. So in terms of outcomes, these are the overall outcomes. You can see the 5 city goes right across the country: Moncton, Montreal, Toronto, Winnipeg, and Vancouver. Now, to understand these graphs, the red line is housing first. And what it's plotting is the percentage of time stably housed in 3-month periods. Now, the blue line is treatment as usual, everything but housing first, what was there before we created these new programs. You can see the first 6 months. Remember, people are moving right into permanent housing with support. So this happens in the first 6 months. It happens very quickly. And it happened across the 5 cities. And then you can see the gap in terms of success when it comes to achieving stable housing. About 80% were successful in ending their homelessness permanently. And then among, though, the people who were receiving treatment as usual, it was really only about half of that, somewhere around 35%. So there's a huge gap between the effectiveness of housing first versus treatment as usual. We also found, though, of course, when people get into housing, they did show significant improvements in terms of on health outcomes, quality of life, and also just in terms of generally their functioning. Now, if we look at the veterans in the sample, it's a mirror image of the rest of the participants. So if you look here at this graph, you can see the veterans who received housing first is the blue line. So again, very quick spike in the first 6 months, moving right into permanent housing, and then stability from there, okay? And the veterans who received treatment as usual, that's the red line here. And you can see here, again, the gap between the veterans who received treatment as usual versus housing first. It's a very large gap. This is a very large effect in terms of an intervention. And then you can also see the non-veterans, whether they receive treatment as usual or housing first, they show essentially the same tendency over the 24-month period of the study. So then you might ask, is it sustained? Does housing stability continue? Well, we were fortunate that the group in Toronto, led by Vicky Sturgiopoulos at the Center for Addictions and Mental Health, they followed their group of people, several hundred people, for 6 years to see if the housing stability that I showed you in the first 24 months continued. And yes, it did. And also there continued to be a gap between treatment as usual. Particularly, you can see the gap, the top graph here is of people who had the high level of needs, who received the housing first that included assertive community treatment. You can see the red line again is the housing first. The people who received case management with more moderate level of needs, there was some catching up, even though there was still a little bit of a gap after 6 years. So economics, for this kind of, because it's a new program, we really wanted to understand the issue of cost benefits, cost offsets, cost effectiveness. First thing, what does it cost? And this is in 2016 dollars. With assertive community treatment for people with high levels of need, it was about $20,000 per year. Now, for people with moderate level of needs with case management, it's about $14,000 a year. Now, this is all in. This is the rent supplements and the community support. Now, this research was led by Eric Latimer, who's a health economist at McGill University and the Douglas Mental Health Research Institute. He found that if we look at reduction in use of health services, social services, justice-related services, for people with high needs over the 2-year period, about 70% of the cost of the program was offset by a reduction in services, okay? For people with moderate needs, it was not quite half of the cost of the program. So it does require some extra resources, but they're very, very reasonable in terms of, remember, ending people's homelessness permanently. So just to end, just a few more slides to end. If we take a look at housing first and put it up against what are considered ideal features of a mental health intervention, and this is work done by Gary Bond and Bob Drake when they talk about what are good mental health interventions, what are ones that we should be putting in place. Well, they should be well defined, and we certainly found from our research with the implementation research that we did, the work we did on fidelity, that it is well defined in terms of what are the pieces of this kind of program. It should be in line with clients' goals. Yeah, sorry, Amanda, how many minutes?
5-minute mark.
Okay, good, thank you. It should reflect clients' goals, and I have to say here, very important. There's research, when we do research on surveys of people who are homeless and ask them what type of housing do they prefer, they prefer regular housing, and they prefer choice, and they prefer to live with whoever they would like to live. And often they'll say, and they'd rather live just in a way that they can be integrated into the community. So this intervention certainly reflects clients' goals. It's also consistent with societal goals, and especially if we look at our national housing strategy now, the focus on right to housing. This is really actualizing the right to housing. I've talked about the effectiveness. Quite frankly, we didn't see negative effects. I mean, there is a group of people who don't settle into this model. It looks like if we look across the board in terms of international studies, including our study, it's somewhere between 10 and 20%. The model doesn't work. So we've got to find a way of getting them into housing and supporting them and helping them establish a life in the community. Long-term positive outcomes, you saw the 6-year sustainability of the housing outcomes. The costs are reasonable. It's implementable. We've implemented Housing First across the country since this study. And it's adaptable to different groups, subgroups. There's an indigenous model of Housing First that they've scaled out in Winnipeg. And in Toronto, there's a model of Housing First based on anti-racism and anti-oppression. So it is adaptable and flexible from that standpoint. So if we talk about where do we want to go with a system, the Housing First and the research on Housing First would point us in the direction of wanting to move people quickly into permanent housing at the top of the staircase, not at the bottom of the staircase. And it's very hard to predict who's going to be successful in Housing First. So if people want it, they should have a trial in Housing First. If it doesn't work, then you have to look at other alternatives that can include more congregate housing with on-site support and so on. This is the implementation of Housing First, which is going on now across Europe. And there's some countries now that are showing at the level, the national level, the kind of outcomes that we'd like to see in Canada. This is Finland, which has been in the news, the media, and so on. We're also seeing it in Norway and Denmark. So you can see the drop in homelessness, and Finland now is targeting 2029, where they'll have essentially ended homelessness across their country for everyone. And the only homelessness that would be left would be more transitional homelessness. So some of the challenges, we do have challenges. I'll just very quickly say we haven't fully embraced Housing First in Canada for a whole bunch of reasons. It's still a work in progress. These are the reasons. We still need to get more rent supplements out there. We're working, I know that CAEH is working very hard on getting more affordable housing in our cities. That's also an issue. But I also think we need to educate people that this is a model that works. And it works with people who have lived such tragic lives chronically homeless. So this is a model that essentially can end that homelessness for good. So certainly there's lots of information. Contact me if you'd like more information about Housing First. There's also stuff on the web. I'm going to share these slides with Amanda, and she can circulate them and so on. And then finally the acknowledgements. So thank you very much.
Oops, you're on mute. You're on mute again.
I apologize. Thank you, Tim, so much for sharing your research with us, or the research with us. Very impactful for sure. I really appreciate having evidence-informed interventions that we can lean into and continue to educate ourselves across the country about what works to end homelessness. I'm just going to share my screen again for just a moment, so bear with me. All right, next up, we have Dr. Cheryl Forchuk, who is the Beryl and Richard Ivory Research Chair in Aging, Mental Health, Rehabilitation, and Recovery, a distinguished university professor at Arthur Labatt Family School of Nursing at Western University, and scientist and assistant director at Lawson Health Research Institute. Dr. Forchuk's research interests lie in the area of mental health, in particular, the development and testing of supportive models of care. Dr. Forchuk's research explores therapeutic relationships and explores systems issues related to mental health care, including implementation of the transitional discharge model, housing homelessness issues, poverty, community integration, and the use of technology in mental health. Thank you so much for joining us, Cheryl. Over to you.
Thanks. And you may wonder, why do I have this picture behind me? And that's because that's where we usually found our homeless veterans. We found they were much more likely to be living in the rough and would have very short periods of stay in the shelters or other more formal systems, like when they were coming, let's say they had an appointment with VAC or some medical appointments, they may come to town, have a very short period. So just reminding people of some of the differences. Of course, right now during the pandemic, we're finding everybody seems, huge numbers of people are living in the rough. I'm going to be going over, I'm going to be informed by 3 different projects, but I'm going to focus on the meat in the middle. But the 3 projects that I will be drawing from, when we started our work in this area, we actually did there was actually no literature on homeless veterans in Canada. And so when because this was a while ago, in the early, just around 2010, 2009, 2010. And what we found at that time is the vast majority of the research on homeless veterans was really coming out of the US and really focused a lot on PTSD and focused a lot on the shelters as used. In fact, some of the studies out of the US at that time were saying up to a quarter of the shelter people were in fact veterans. But we felt it was very important to look at the Canadian context. Our military culture is very different in terms of the types of missions people are on, where they serve, how we organize at the age, at the point, because people often will have their education more upfront and then the specific training and then the military deployment. So there's several years difference, really, when you boil down to it. So when we started the study, we thought, given there's nothing, the first study we wanted to do is find veterans who were homeless and find out what was their story. How did they become homeless? How did they think that their veteran service related to their homelessness? And what did they think would get them out of homelessness? And then the strategies they suggested really formed the backbone of the next study, which was the implementation study, which I will be spending most of the time on. And then the third thing, I'll just draw some, maybe more around the questions or some of the points, is we then did a knowledge descent. So the demonstration took place in 4 communities. The demonstration, or the knowledge translation, we went to an additional 10 communities to talk about what we learned and work with people from the homeless serving sector and the veteran serving sector. I also think it's really, I'm very glad and appreciative to be here, particularly coming from London, Ontario, who have really led the way in terms of our many, many community partners on this movement. And I was so glad to see Elle Lane from the City of London is also on the call because she oversees the veteran program in London today. And London, I think we should acknowledge, is the first city in Canada that has 0 functional zero at veteran homelessness. So it's not coincidental. I think that because we were partnering with the City of London from the start. We had our first study starting there. Jan Richardson, which is with the city, led the first demonstration project in terms of assisting with all 4 sites. And today we see the result of evidence-based policy that we actually get to zero. So going to my slides, Jan is retired now, but acknowledging her part in this. And I said,
we can't see your slides. I apologize.
Pardon me? Oh, sorry, it's not the sharing. Okay, I got to do another, press one more button, sorry.
There you go.
So there we are with Jan. We've got in brackets retired. But as I say, the city has been so involved and so supportive through all these projects. I'm going to focus on the evaluation project. I'm going to take a little bit of time talking about these principles because I know we have a lot of policy people here. And the important thing is this really came we found our population was so different from some of the literature, but similar to some of the work from Milroy, who comes from the UK, and then later some other people in Australia, because I think our military systems, our armed forces systems are a little bit more similar. So one of the big things, when I asked Sue Ray to work with me on that first project, because she had expertise in PTSD, and that's what the literature was saying, we ended up oversampling in that first qualitative study because we were not hearing about PTSD. And we thought, oh, we must be having a sampling error in London because we have the OSI clinic at our doorstep. So we'll go to some other communities in Ontario. Oh, maybe Ontario's doing a good job. We ended up going across the country. We really were not hearing much about PTSD. Now, as you saw, I'm the research chair at Parkwood. We have the operational stress injury clinic right there. PTSD is the most common reason people will come to the operational stress injury program. It's a very significant problem. It relates to suicide. It relates to family impact. However, it is not at all a major player in terms of veteran homelessness in Canada. Again, in the US, definitely true. When we did that study, we actually had 2 American veterans who were not eligible to participate in our study, but it's just, so we didn't officially enroll them, but they wanted to talk to us anyway. Both of them talked about PTSD. So I'm not saying the American studies are wrong. I'm just saying that we have to consider the context. So what did the veterans say that they wanted? They said they really wanted to focus on veterans helping veterans. Now, part of it relates down further around the addiction. So instead of PTSD, what people talked about was addiction as being the foundational issue. And we know that quite often addiction is a secondary thing from PTSD. That this was not what they were describing. They were talking about a primary problem around addiction, and primarily alcohol addiction, by far and large, alcohol addiction. They talked about how in the Canadian context, that is very much part of the culture of the military. And I know some people don't want to hear that, but this is what people talked about, that at times they were ordered to the mess camps, that they did not see that they had the addiction problem so much when they were in the military, although their drinking certainly increased during that time. But when they left the military, they had difficulty adjusting to civilian life, and then they started drawing on that coping strategy. Ironically, although I asked an expert in PTSD to work on this, I have a lot of experience with addiction, having that my first nursing positions were in the addiction field. And my master's thesis all focused on addiction and specifically alcoholism. So in some ways it was familiar territory. And one of the big issues with any kind of addiction is your self-esteem suffers greatly. So a lot of the strategies that came up from this group related to the idea of this huge impact on self-esteem. They very much valued, and an important part of their self-concept was being a veteran, but they felt that they had let down that part of their personal identity by having the addiction. So so one of the reasons they wanted to focus on veterans, helping veterans, was to reclaim this part of their identity. And that they felt that that was very important. They felt that they did not fit in with the general homeless population. And when we looked at some of the stats in terms of education level, in terms of some of these issues, we could see that very often we did find someone in a homeless shelter who was a veteran in for those few days. They were the one offering to clean the table because they found the lack of structure was very distressing. That it flew in the face of the culture within the armed forces. The phrase "loosey-goosey" came up 100 times. You know, and so they really wanted to be with other veterans to reclaim that identity and also to be separate. This is self-respect. They wanted more structured environments. As I say, they didn't like this loosey-goosey stuff. They wanted to know what was happening when. When we did those workshops at the end, as a semi-joke, each of those workshops I started 1 minute late. And I would ask the audience, who would be people from the homeless sector and people from the veteran serving sector, who noticed I started 1 minute late. All the veteran serving sectors noticed that and were offended. But that's why I only did it for 1 minute. I didn't want to overly offend people. Nobody from the homeless service sector did it. 1 minute late is on time. 10 minutes late is on time. The culture of these different groups is quite different. Focusing on the transition to long-term housing. This is not about transitional housing. They did not want long-term transitional housing, but what they said is they needed time to adjust to being housed. And you'll see in the examples later, people had often been rehoused many, many times, but not left with the proper support, which would come from a housing first perspective. People don't like to see veterans homeless. So they frequently will just, they'll put them up in a hotel. They'll do something short term, but they really need that long-term support. And they really talked a lot about it. We were looking at having a core of veterans. We talked about harm. Tim's already talked about housing first. We won't repeat that, but also the harm reduction strategy. We know harm reduction is a best practice when dealing with addiction. And it actually is another thing that kind of flies in the face of traditional approaches in terms of veterans. And the veterans talked about this all the time. And some of the agencies talked about that in the military, if you're given an order, you should simply follow it. So if you're in a place where the issue is you're not supposed to use substances, then just don't use substances. Well, that doesn't really take into account an understanding of addiction. We wouldn't have addiction if all it took was just stop. So this often created a conflict of vision. So they really felt that when they had accessed programs that had kind of a zero tolerance policy, they ended up losing their housing, losing the programs. And they felt that this was super important. Again, these are some of the things that then therefore we had to do. The peer support, I will also say, I just wanted to highlight, it has to include so basically people in this situation who are homeless and veterans, they're covering two different cultures. There's the homeless culture and that military culture, and they're quite opposite. So the peer support they want is someone who understands both cultures. That can be in many ways a cultural brokerage. And it involves collaboration between these two groups. So I had a call out to Al at the beginning. I also noticed Dave Gordon is on the call, and he's really was helpful right from the beginning on this from the Royal Canadian Legion. When we talked to people about what service did they access first when they became homeless, it was the Legion and the Poppy Fund. So when we wanted to look at who needs this information, Dave and others from the Royal Canadian Legion were very helpful in identifying what legions had the most requests for the Poppy Fund. And it was these smaller communities, often these rural communities. It was Surrey, not Vancouver. It was the Paw and Flin Flon, not Winnipeg. Lower Saxville, not Halifax. where we were seeing most requests. So it's important. And when we did those workshops in those 10 communities, we found that the homeless serving sector did not understand the veteran serving sector and vice versa. The real goal was in having those groups work together.
5-minute mark.
Okay, so I told you I was going to spend more time on the beginning. These are the 4 sites we used where we implemented. We had everybody could use different strategies, but keep to the principles. When we get to the outcomes, very similar. When these are the traditional costs Stephen Gates and the Homeless Hub in that period had. This is what the sample looked like. These people have been 25 years out. They've been homeless about 10 years. They had a lot of homelessness in terms of the total time. But one of the things is in the last 5 years, they had on average been housed 6 times, but it didn't stick. And the reason was the focus was on just getting them housed, but not looking at the addiction issues, the harm reduction, and sticking with them through that transition while they got used to being housed. There's a lot of differences from the normal homeless population. In particular, look at the large number that had completed post-secondary education. This is very different from the general population. You can see where people were deployed, average of over 2 years. When we implemented, we saw community visits go up, which was what we were hoping for. We want them to address their health and social needs, which have been left, but all the things related to crises went down. And these are just some pictures of this is example of what went down. And we were following them over a 2-year period every 6 months. So the crisis services went down. Their satisfaction with their living went up over time. Obviously, they weren't happy being homeless. But look, even that 6 months into housing, they were not yet happy with their housing. It really took time before they actually became happy and settled in their housing. 18 months before you see some of those really big improvements and holding out. So I think that is important. You can't expect someone who's been homeless for 10 years to suddenly adjust and say, yeah, I'm happy. Most of the people had a knapsack packed at the door in case things fell through. An overall sense of well-being. And again, it took time to get there. We also had focus groups with the veterans, with the different agencies that were providing support and those that were referring. Obviously, the veterans liked it, particularly as they got in, having the home. The fact that they kept their housing this time was very important. This issue of respect, how they were functioning, how they participated was fantastic. The sense of belonging was reclaimed, particularly around that veteran sense of homelessness. So one of the things in terms of structure that we really found as we went through those principles, it was helping people create their own structure. So one of the things, even after the first set of focus groups, we actually ended up hiring recreation therapists in most of the programs to help people learn how do you create your own structure. Structure is so important, but structure in civilian life is just not as present. So how can you create that yourself so that you're more comfortable and you're more settled? And that was a really important piece of it. And I also really want to thank the veterans who participated in the study. I should say we only had one veteran out of all those veterans that participated across all 4 sites. I can't remember, I think that was 78 total who returned to homelessness. So it did work. And that person I think was temporary. He even said, I'm just not ready yet, I will be back. The veterans, I never saw, like it was the focus groups were incredible, like especially the last set. All the focus groups basically took 2 hours. Everybody would show up because there's a thing in the military about you never leave your brother behind. And what they said was this has worked, but it worked for me. And I know there's veterans still out there on the street that need this. So I want to make sure you have absolutely every piece of information you need to help our brothers who are still on the street. It tended to be very intensive. We tended to have pretty much everybody wanting to participate because of this very strong value of helping each other. So as I said, listening to what veterans, the stories of veterans, how they became homeless, learning from them, what was it that they wanted? That's not just a cookie cutter in terms of what we normally offer. What's different about what they identify was very important. Addressing the alcoholism, but having that harm reduction approach, not expecting that people can simply stop. And since I got a little bit of time, I will give you one example.
Sorry, you have 1 minute.
1 minute, good. So I'm going to give you the one example on harm reduction is my 1 minute thing. We had one veteran who, I don't even know how he stayed alive. He had 20 years of drinking non-palatable alcohol, which means you should be dead. And you should be dead several years ago. And I remember talking to him so many times over the years, so I kept going back to this site. And so his goal was to only drink vodka for the initial goal. And I go, why vodka? He says, well, it's expensive, it's clean. I've been, drinking all this other stuff, and I can do that as a transition. Because it's expensive, it limits how much I can drink. And then I remember after a year, he said, okay, I've had a year of only drinking vodka. Now I'm going to start cutting back. And actually did get to the point of abstinence, but you could not possibly take someone with 20 years non-palatable alcohol constantly and expect them to move to abstinence. And certainly, like, some of our programs had started off with a lot of veterans involved that wanted to start with that zero. We had in one of our other sites a different homeless serving agency that was not on board with harm reduction, different city, so it wasn't the same person, who did a home visit, found a bottle of vodka on the table and poured it down the sink, which is actually theft from a harm reduction. All I could think of, what if that had happened to that person who had been drinking non-palatable alcohol for 20 years and was having this as his priority strategy? Unfortunately, it was different people, but it was very traumatic for the person it did happen to. But I just used that to illustrate harm reduction. These are some contact informations. That link at the bottom is just literally came out today on the 4City project, highlighting some of the qualitative results. So maybe what I will do is I'll also copy that later into the chat. So thank you all, and I'll wait for questions at the end.
Thank you very much, Dr. Forchek. Very insightful as well, and you can definitely see some synergies between the two presentations. I'm going to now move us into the final presentation, so bear with me as I just share my screen here. Very pleased to invite Adam here today. Adam's responsible for creating and constantly improving a standardized approach to learning across Built for Zero portfolios in the United States, while also leading knowledge capture and dissemination for targeted strategic learning questions. Prior to joining Community Solutions, Adam worked for the U.S. Department of Veteran Affairs in the National VA Homeless Program Office. He has over 18 years of experience working with homeless veterans and programs as a direct service provider, a homeless program manager, and also at the national level. Adam has a BA in psychology from Ohio University and MSW from The Ohio State University, and he resides in Columbus, Ohio. Thank you, Adam, so much for joining us today, and we look forward to hearing about the U.S. Housing First model.
Thank you so much, Amanda. I really do truly appreciate the opportunity to share some of the learnings that we've experienced in the United States around implementing a large-scale Housing First model called HUD-VASH. So I will get into details. Let me just share my screen here. Just give me one moment. There we go. So I'm only going to be able to touch the surface. So I want to acknowledge that given 20 minutes, but I'm hoping, one of the goals that I have from this presentation is to share with you all how, what we learned in the United States in the 13 years of experience and learning that we've gained in the United States around implementing a housing first model for homeless veterans. We can impart some of that knowledge to you all in Canada. I also want to say thank you to Amanda and the Bill for Zero Canada for inviting us to be able to share some of this information. I want to thank you all on the call, both of you all who work day in and day out to end homelessness in your communities, and also the veterans on the call who have stood arm in arm with our American soldiers over the years to support democracy around the world. So again, I'm very happy to share this information. I'm going to focus on three things. One, the progress that has been made over the last 13 years around veteran homelessness in the United States, some of the lessons that we've learned from there, and some of the things that we could see improve. Some things that, you're looking at implementing models like these, learning from the United States, and looking at ways to improve the model. So let me just real briefly share some of the, real briefly, as Amanda said, I work for Community Solutions now, Community Solutions in the United States, and support the Bill for Zero movement, which is a movement of more than 125 global communities working to measurably end homelessness one population at a time. So we work with communities, mostly the United States, but we also work with governments and communities in Australia, in Canada, in Denmark, and other countries around the world. We have seen dramatic evidence. We've seen evidence of the model that we work and I work on it. And I encourage you all, if you're not familiar with what Community Solutions does, take a look at our website, Community Solutions, if you Google that, or look at Bill for Zero Canada, which adopts a very the same model that Bill for Zero does in the United States. I want to highlight that first number there: 13 communities have ended veteran homelessness, and this has been this is data driven and proven that 13 communities in the United States have ended veteran homelessness, which is no small feat. And through the work in those communities and service providers and community partners, we've been able to achieve that goal. So let me just share with you some of the key lessons that we've learned around the HUD-VASH experience in the United States. And let me first define what HUD-VASH is. So in 2008, the US federal government made a commitment to allocate 10,000 vouchers, housing subsidy vouchers, targeted towards veterans experiencing homelessness. These 10,000 housing vouchers were paired with VA. So VA, in the United States is an integrated healthcare system. So I know it's a lot different than how it is in Canada, but in the U.S., VA is a federal medicine system. 140 medical centers across the nation and some of our territories. And the housing vouchers are allocated by Housing and Urban Development. So they release the subsidy, and then the VA provides the clinical services. The clinical model that's used is housing first, and using assertive community treatment that was mentioned earlier, as well as intensive case management. Those are the two key models that are utilized in HUD-VASH in the U.S. So let me just share. In 2008, up until this past year, over 100,000 vouchers have been released to communities around the U.S. And what has that resulted in? Currently there are over 80,000 veterans, formerly homeless veterans, who are no longer homeless because of the use of the HUD-VASH housing subsidy and the housing first model. This has led to, and we know that HUD-VASH has been the key driver for the massive reductions of veteran homelessness in the United States. 50% reduction in veteran homelessness since 2010, with HUD-VASH being the key driver for that reduction. And on the ground floor, when we began to implement, when the federal government, when HUD and VA and the White House got together and said, we need to address this issue of veteran homelessness in this country because it's absolutely unacceptable. We used one model, and that's Housing First on the ground floor. The decision was made on the ground floor to use the Housing First model. So we've seen tremendous progress over the last few years. You will see here that it has flatlined somewhat, and I'll speak to that in a few moments later on in my presentation. I also want to share with you my kind of personal experience with Housing First. As Amanda noted in my introduction there, that I've worked with homeless veterans pretty much all of my career. Early on in my career in the early 2000s, I was a homeless outreach worker, going out in the streets and the shelters in Columbus, Ohio, and supporting veterans to get services like healthcare, maybe vocational rehabilitation services, transitional housing. In early 2000s, one thing I just noted, and it was somewhat ironic, because we always called ourselves the Healthcare for Homeless Veterans program, but housing was never a part of that title. And I would work with veterans for years in engaging them to try to get into transitional housing, for example, using that staircase model that Dr. Aubry had mentioned earlier. But there was that never achieved getting so many more veterans off the streets. I can tell you one story of a veteran that I knew in 2004 when I first met Frank, who lived underneath the bridge in Columbus, who had spent about 10 years in the U.S. military. And after he got out, and at that time, the mid-90s, when he got out, there were not many transition resources. So he gets out of the military, has struggles with alcohol and mental health, and can't find a job, and he ends up living under a bridge in Columbus. I remember walking up to him and asking him, if he was a veteran. He said, yes, and I get all excited. I'm like, okay, so now we can do something. And that led to the question from him to me, can you get me housing? And I say, no, we're a homeless program. And I offered him transitional housing. And he said to me that, I've got serious PTSD, both from childhood trauma and from my experience in the military, and I cannot be around people. I would much rather stay in my tent underneath this bridge. It wasn't until 2008 where I could go back to Frank and say, I've got your housing. And that was the year that Columbus received our first allocation of HUD-VASH vouchers. And he was the first veteran that was housed in the program. And 13 years later, he remains housed. Are there ebbs and flows? Yeah, sure. But I could tell you, from my experience and from the research and from so many others who have implemented this model, that with a home, it's much easier to gain access to those resources. It's much easier to achieve sobriety. It's much easier to get employment. So I use that as an example in knowing how that shifted, that the decision to use Housing First as a model in the US to end veteran homelessness shifted the whole mindset. And, as you can see in this graph, seeing a 50% reduction in over 80,000 veterans housed who are no longer homeless. Okay, so I'm going to speak to 6 key points, and I'm getting into the operations of the program, just to kind of impart some knowledge to you all. They may or may not be in the Canadian context. They may not be viable. But some of the things that when I sat down and really thought about the things that really did work, with the HUD-VASH program, these are the things that we have found to be very effective in using the model. I also want to put a caveat there. I'm not a representative of the federal government, so I'm not speaking on behalf of the VA, but I'm speaking on behalf of my own experience, the research, and then my work in community solutions. So 6 features worth adopting. One is that joint commitment to evidence-based interventions and models. As I mentioned earlier, Housing First, committing to Housing First as a model. And implement and provide training and resources to implement what works, whether that be making sure that's Housing First, but I heard, motivational interviewing as a model, as an intervention, harm reduction models. There's a tremendous wealth of resources when it comes to clinical interventions to people who are experiencing homelessness. And having joint commitment early on will be essential. It was not easy to implement Housing First as a model in the United States. I remember early on in some of the conferences I would attend, there were shouting matches about this between leaders in the VA. But coming down to consensus around this as the model was the absolute key to us getting the reductions and getting those veterans off the streets. 2, multidisciplinary services. Don't limit the type of discipline that provides services to veterans. Initially, we used social workers only. Over time, we have found that multidisciplinary, whether it be peer support, veterans, formerly homeless veterans working with veterans, nursing staff, vocational rehabilitation specialists, access multidisciplinary services to help ensure that veterans receive the services that they need. 3, removing barriers to admission. Early on in the decision to and when the policies were written up for the HUD-VAST program, we decided to take a deep dive into what those admission requirements were on the HUD side and removing those barriers. And that includes, removing requirements around prohibiting prior evictions or criminal histories or certain documentation requirements. This helps streamline the process for veterans getting off the streets and into housing. Number 4, no limitation of program participation. This one too, and I've heard elements of this in the other presentations, but don't limit the number of times a veteran can access the service. One thing that we realized when we started to shift our thinking around it being a veteran failure that they didn't succeed in the program to a system failure, then we started thinking about how we could readjust our programming to help that veteran sustain housing. So even if it doesn't work the first time, maybe the second or third, keep that door open. Number 5, separate the services and benefits. So as I said earlier, the housing vouchers administered by HUD and our local public housing authorities and the services are provided by the VA. They need to work hand in hand, but they shouldn't be doing both for a number of reasons, not the least of which is when it's difficult to build rapport with the veteran when you also have a benefit. You're also administering the benefit. So I just want to make that clear. Number 6, comprehensive data systems. Early on in the HUD-VASH initiative, the decision was made to have a comprehensive data system to help support understanding and tracking and performance of the model over time, and that continues. The comprehensive data systems that the VA uses continues to tell us at any point in time who the veterans are that are in the program. Let me speak, kind of think through about some of the things worth improving. So if we could, enter a time machine and go back in time, these are some of the things that we would have probably adjusted. Number 1, commit to a shared aim to end homelessness. So right now, the program operates more focused on program level outcomes instead of looking at it as part of a bigger picture to end homelessness. The main focus is on the program level outcomes. So especially, and I'll get to this in number 2, is tying the real-time data that you have. If you know who is experiencing homelessness in your community, tying the performance measurement system to that to ensure that these vouchers and these resources are driving an end to veteran homelessness. And I'll get to 2, having real-time quality data. One of the challenges with the VA model in the United States is that we only use the point in time count as the barometer of our progress towards ending veteran homelessness. That's one time a year. What we've seen in communities across the nation, though, those that have adopted a by name list methodology know in real time how many veterans are experiencing homelessness, and they can act on that. So where possible, using real-time quality data to know if the service is making the impact that it's intended to. Integrating with coordinated assessment at the outset. If we could go back in time in 2008, coordinated entry did not exist as a model in the United States. What we know now is that if it were, we probably would have tied it to that model. And communities that do that are those that are the most successful in reducing their homeless veteran numbers.
5-minute mark, Adam.
5 minute or 1 minute?
5 minute.
5 minute, okay. Number 4, integrating data systems. Now, I mentioned earlier that we have VA has a comprehensive homeless data system. However, it does not speak to the broader HMIS system. And so what we have found over the years is that communities don't have the full picture of homelessness, even homelessness among veterans, because there are veterans that access this community system but do not access the VA. So on the ground floor, if we could go back in time to better integrate those systems so they can speak to each other or use the same system, would have allowed us to have a broader view of homelessness in a community and develop strategies to reduce homelessness. Number 5, can't reinforce this more, mitigate housing affordability barriers. As I mentioned earlier, you saw that in the reduction line. You saw over the last few years in the US, veteran homelessness has not changed that much. And one of the key drivers of this has been the housing affordability barriers. We did not anticipate this to be such a big issue in 2009. We had no problems housing veterans in 2009, 2020, 2021. That has fundamentally changed, especially in our larger cities, and especially those along the West Coast, where housing affordability has prohibited quite a few veterans from accessing the services. So early on, develop strategies in the future, if they don't exist now, to mitigate housing affordability barriers. And then number 6, develop your learning and evaluation systems and continuously learn. And also avoid being inflexible with admission requirements, because what we learned over time is that the population changes. We found over, in the first 5 or 6 years, the number of veterans who were chronically homeless reduced. And I know that the US has a different definition for chronic homelessness than Canada that's much more stringent. And what we continue to reinforce that only chronically homeless veterans should be housed. However, there just wasn't the population there to house them. So, and it took a long time for us to change those guidelines. So continuously learn about the population and make adjustments over time to make sure that the veterans that need the service are getting it. And right now, I don't know what it's like in Canada, but in the United States, the average age of a veteran experiencing homelessness is about 56 or 57 years old. And now we're experiencing what we're considering a gray wave in veteran homelessness that is requiring us not just in the VA, but around the country to rethink how we design services and housing first approach for veterans who are older. I've included some resources here. All this is public facing. If you want to dive into any of the policies or the resources that are available through HUD or VA. I also forgot to mention in the last few years we've done work with our tribal communities as well, and implementing a HUD VASH program in tribal areas in the United States. Which is actually just expanded in the last year. So the VA has really tried to expand the scope and the scale of the work done in the HUD VASH program. And again, I just want to say thank you to everybody for this opportunity to present. I hope that this is just the start of a discussion, and that we can open up the dialogue around what we've learned in the United States and help Canada. Help inform Canada on implementing models like this in your country. So thank you again, Amanda. I'll turn it back to you.
Thank you so much for sharing your insights. And before we jump into some questions, I just wanted to highlight a couple of key themes from all of the presentations to summarize things. And Savannah, if you have anything to add, please feel free to jump in. But housing first means that we have a standard definition of what permanent housing is, and it's not housing only. There's supports that are attached to the Housing First program. The importance of having subsidies and those support services, and the support services being delivered by experts in the field of mental health and addiction, and not relying solely on volunteers, although there's other services and supports that can come into complement, like those recreational services that Dr. Forchuk mentioned. That housing may not stick the first time. When people have lived a particular way for a very long time, there's patience and I think non-judgment around having multiple maybe evictions and moving back in, but adhering to that right means that we continue to work with the individual irrespective of the challenges that may take some time to stabilize, as Dr. Forchuk mentioned. Veteran veterans that are experiencing homelessness and the general homelessness population have very similar needs, most often mental health and addictions. And there's benefits associated with being a veteran in terms of services and supports that are available that aren't available to non-veterans in this country. And so there's an advantage and an opportunity there to lean into being able to support veterans with more than just housing and homelessness resources. And this synergy between having veteran organizations very clearly working with the homelessness and housing organizations and local communities is pivotal to a veteran receiving the wraparound services that they need, both from their military experience and their current homelessness experience. And I just want to say on that note, if you are a veteran organization and you're working with veterans experiencing homelessness, I strongly encourage you to please reach out to your local coordinated access system. Coordinated access essentially is all of the service providers delivering housing and homelessness services in your community, as well as veteran services in your community, coming together to problem solve people's housing needs and stabilizing individuals in that housing. And so no one can do it alone. We need to work together on this. And I strongly encourage you to reach out and get connected in so that you're working and have access to all of those services and supports across the community and breaking down those silos. And so if you're not sure who that is, I will leave my contact information at the end. So feel free to reach out to me. A copy of these presentations will also be available on our website. Again, if you're not sure where to look on our website, feel free to reach out to me or to the contact information that you have from this webinar. I'm going to start by jumping into a couple of questions here. And so the first one for you, Adam, is who administers housing vouchers through the HUD Voucher?
Yeah, so HUD, United States Housing and Urban Development has the authority, the congressional authority and the funding to administer the vouchers. And they go to public housing authorities and communities across the United States, which are typically not their county or local agencies. So they administer the vouchers, the public housing authorities do.
Sorry about that. I was just trying to find my off mute button. Cheryl, this one's for you. There was a question about, you mentioned recreational supports, and are you aware of what type of impacts COVID has had on those recreational supports?
What I would imagine is that that has certainly curtailed the recreation for anybody in Canada, on a totally different project. I've been going across the country to every province and territory during the pandemic and talking to people experiencing homelessness, and certainly access to resources generally is difficult. The kinds of activities, there would be some things that could be done virtually, because some of the things was around the planning of connecting with community resources. Interestingly, it was things like art galleries and museums that they very frequently wanted to do, which would have been closed. But it's also about how to plan your day and how to create that structure internally, which could certainly still be done virtually, even if people can't physically get together. And that was the thing that the veterans really said. Like they wanted to get out, they wanted to engage in these community events, but they really wanted to learn how to create their own structure so that this lack of structure didn't bother them so much.
Just if I could add, Amanda, just because it's, when we talk about housing first, you work on the housing first, right? But it's kind of what comes after once people are housed. And we know, people talk about loneliness and social isolation and so on. So we need to address that. And we're actually doing a small project now in Ottawa where we're trying to bring in the use of what's called social prescribing, which comes from the UK, into two housing first programs, one at CMHA Ottawa and the other at Options Bytown, with the idea of working with people to identify, okay, I've got my housing now, what are the kinds of things I want to pursue? Whether it's arts, culture, sports, recreation, education even. But I do think we need to integrate with these programs, you know, things that are going to make people's lives fuller once they've ended their homelessness.
Mm-hmm. Yeah, and the full life, I think, would apply to anyone experiencing homelessness. The specific thing that's different for the veterans is this need for structure.
Mm-hmm. Yeah, thank you for that. I see a question from Cameron about the validity of by name lists, and this continues to be because of some veteran organizations are still learning about what all this means in terms of how the homelessness serving sector is working. And Adam, I invite you in to share, you know, from the community solutions perspective, why a by name list is important. But what I can say is based on your question, Cameron, you're suggesting that the Legion has its own list of veterans that they're working with in real time, therefore questioning the validity of the by name list. So what I can say to you is the by name list isn't just about one program serving a cohort of individuals. The by name list is a list of every single program in your community that is serving somebody experiencing homelessness, that is contributing to adding and referring them through the by name list, updating that by name list, and then monitoring and tracking the outcomes based on move-ins and returns to homelessness if housing is lost. And so it's a system level real-time list of known individuals, including veterans experiencing homelessness in the community from both veteran service organizations and housing and homelessness service organizations across that city. It's not an individual program list. You know, we won't necessarily know every single human being out there that is experiencing homelessness in every community. So for example, you know, that's like saying, you know, we need to know every single person that has cancer to end or to treat people who have cancer. But when they do get diagnosed and identify, then it's on the healthcare system to do something about it, just like it's on the homelessness serving system to do something about it. And so, you know, we want to make sure that we're not just siloing ourselves by programs, because people go across programs. They might access 10 different programs in the community, and having a real-time by name list allows you to see that movement and who's supporting them to become more efficient and effective in your efforts. Adam, do you have anything to add to that?
You know, Amanda, I agree with all of that. And I, you know, I can share again, the by name list methodology that's been established, I think, I mean, really since 2016, we have seen in the United States, communities that have those by name lists, again, they know at any given time who's, you know, the majority of who's experiencing homelessness, and they can tie their resources to those veterans. They can also monitor kind of where improvements need to be made in the system. So, you know, again, this is a model that in many communities around the US, and I know in Canada as well, has been implemented, been proven to be very effective in knowing, you know, giving visibility into how many veterans or chronically homeless individuals, or, you know, general population of homeless, how many are experiencing homelessness, so that, you know, resources can be aligned to us to support them.
Yeah, and if a community, you know, if there is validity concerns, then it would be that community. I would put it back to the community to say, like, you know, it's on all of us, all of you in that community, to ensure that people are getting referred and connected in through the by name list so that they can receive the wraparound supports. Tim, I have a question for you about clarifying what is meant by housing in the Housing First context, and what are the characteristics of being housed. And I think this might tie into some of that transitional modeling that came up in terms of the step model that you had identified.
Yeah, well, the model we tested, Pathways, the housing is regular housing that people choose. In fact, the process at the beginning is finding out what, you know, where people want to live, and what kind of housing and with whom, and so on and so forth. And then there's kind of work to do to try to get people into housing. As I said, the preference has been very clear with research that it's people want to live often on their own, if they're single, you know, and they just want to get integrated into the community. So that's what it meant by housing, and the model has been applied in private market rentals, but as well in social housing, more so in Europe, in some of the countries that have more social housing than we do in Canada or that exists in the U.S. But yeah, no, that's the intent is kind of regular housing. Now, there's a small group of people that may want to live in some kind of communal housing, and it would be nice if our systems could accommodate that. It's the same way, there's a small group of people, families who want to live in co-ops. We have co-ops, but a concern I have is that we're moving because of just the way the funding is being doled out right now, federally and provincially. We're moving to more and more specialized communal housing, and it's not the predominant model of housing that people want, and I think including veterans. But it would make sense to do a needs assessment and find out what the preferences are for veterans. I mean, it's easy to do. I think Cheryl has done that work at one time in London, I think with Jeff Nelson, Cheryl? So, it's something we need to do. In fact, I've advocated that we should be asking people when we do point in time counts about their housing preferences. I mean, if, that should be part of a point in time count, so.
Sorry, just to clarify, I think there was a question about, is somebody considered housed if they're, if they don't have their own tenancy, for example, or if they're living in a supportive housing model without, any type of
I think
of their.
Gotcha. No, they have to have a lease, right? With the Housing First model, they hold a lease. They have all the rights and responsibilities of a tenant, and they sign a lease. They sign the lease, not an agency or some other organization on their behalf. So that's actually part of the model, the type of housing that we're talking about.
Great, thank you. I have 3 minutes left, and I just want to make sure we try to get through as many more questions as possible. How are the experiences of women veterans approached? Are their current services set up to equitably provide the required resources and supports for women? So does Housing First maybe work for women, and what are some other contexts? I see Cheryl has her hand up, and Tim, I think you might want to.
Yeah, one of the things we had fewer women in the study, but certainly the whole issue of neighborhood of choice. Some of the veterans we found were choosing congregate living because they wanted to be close to other veterans. So we did have that available. None of the women wanted that. And many of the women also had children. So I think when we're looking at that, that's something to keep in mind, because some people, when they're setting up programs for veterans, they're assuming, because many actually want congregate living, but keep in mind that will leave out women. It also leaves out men who are married or caring for children.
Yeah, and just those are important points. We didn't find any difference in outcomes. So in terms of people establishing permanent housing between men and women, there was no difference. The other thing I'll say, just so that you know, there's a very interesting model of Housing First being tested in Washington State through the Bill Gates Foundation for victims of domestic violence. So it's applying the Housing First model. And I can't remember the professor's name who's at Michigan State, but if anybody's interested in finding out about that, it's on the website, and there's even a toolkit for that kind of application of Housing First.
There's also a Women's Housing First program in Hamilton, Ontario, and Housing First programs that take that trauma-informed approach. Last question here for the day is, were there any nuances in case management in terms of approach, delivery, quality, and intensity that helped to support the success of the Housing First participants? Can anyone speak to this issue? I will give the quick and dirty, and then I'll pass it over. The answer, I think Tim and Cheryl would likely say yes, it's based on people's level of need and preferences. But I will pass it over to Tim and Cheryl to give more context.
Yeah, and this is where, quite frankly, we have failed in some of the Housing First programs, in that the case management is not broad enough or intensive enough. We've only focused on housing, and it should be much broader, so that's important. The other approach of case management that fits like a glove with the values of Housing First is the strengths-based approach to case management. So I think that's really something to look at, and particularly in terms of working, with veterans, because it's future-oriented, it's goal-oriented, and so on.
Thank you so much for your time, for your expertise, for your knowledge, and thanks to all of you who are on the call for doing the heavy lifting every single day to support veterans. For those of you who are on the call who have served or are serving, thank you for your service. And we hope this was informative and valuable for you. Again, presentations will be shared. My contact information is here. It's amanda@cah.ca. Feel free to reach out and connect with me if you'd like to receive a copy of the presentation or want to know where things are located. Yeah, thanks again to all the presenters for taking the time today. Really exciting, and I'm sure this is just the beginning of these conversations. Thank you so much.
Great. That's good. Thank you.
Goodbye, everyone.